Thank you, Dr. Selecki, for that kind introduction. Good afternoon. Thank you all for coming. My name is David Millett. It's a privilege to be here today to tell you folks a little bit about some of the newer developments in the treatment of epilepsy. I'm going to spend a few minutes talking about the diagnosis of epilepsy and just review some basic information about the disease itself, or the diseases. So disclosures were already up. I will indicate that some material was provided by device companies, although this has been vetted. At the conclusion of this lecture, you'll be able to do the various things that we told you would be able to do in the email and in the first slide. So I'm going to start, as I mentioned, with some basic introductory material. I think we all have a general sense that we know what epilepsy is, but it's a good idea to just cover some of the foundational material, because with the advent of technology, some of the definitions do change a little bit. Epilepsy is a disorder or a disease of brain function that predisposes a patient to recurrent and unprovoked seizures. The current diagnostic criteria recognized by the International League Against Epilepsy, the ILAE, consists of three possible sets of criteria. The first is 2 unprovoked seizures, more than 24 hours apart, so those outside of the influence of known proconvulsants such as Wellbutrin or Tramadol, withdrawal from alcohol or benzodiazepines, what we call acute symptomatic seizures related to traumatic or penetrating brain injury, stroke, etc. A second potential criteria would be 1 unprovoked seizure with a greater than 75% chance of future seizures based on neurological examination and diagnostic testing. That typically includes both an EEG and some neuroimaging, preferably an MRI. And finally, at least 2 seizures in the setting of reflex epilepsy. This is a fairly uncommon situation, but one that needs to be identified in order to capture those under an umbrella definition. So let's talk for a few moments about the causes of epilepsy, because epilepsy isn't a disease as we often discuss it. Seizures are a symptom of brain malformation. They're a symptom of either excessive excitation, deficient inhibition, or hypersynchronization of brain activity. But they are a symptom of an underlying disease, and that underlying disease relates to the etiology of the epilepsy, and that can be, as you see listed on this slide, due to a variety of pathologies. So the set of pathologies that garners the most attention, largely because it can be easily studied and it affects youngsters, is genetic. So, for example, childhood absence epilepsy, juvenile myoclonic epilepsy, and a host of neonatal and infantile epilepsy syndromes that you'll see on the following slide. Developmental abnormalities, these are typically malformations of brain development, such as malformations of cortical development, MCD, or tuberous sclerosis complex, that's a neurocutaneous disorder, resulting in multiple tubers or benign growths in the brain that tend to be highly epileptogenic. Traumatic brain injury, infections, worldwide neurocysticercosis is still a leading cause of epilepsy, HSV. In addition to tumors, strokes, dementias, a growing number of autoimmune conditions, including antibodies targeting the NMDA receptor, which is one of the glutaminergic receptors in the brain, excitatory receptors, LGI1, and GAD65. So these are neuronal-based, either membrane-bound or cytosolic enzymes that can have antibodies mounted against them and generate seizures. And finally, cryptogenic. So in the traditional literature, it's stated often that about 60% of epilepsy is actually of unknown cause. The standard diagnostic evaluation does not detect any clear etiology for seizures, although that number is shrinking to some degree. This is a very busy slide, and I put it up here simply to remind myself and everybody here that this is a very complicated group of conditions that can be understood in numerous ways. The first major classification or way of breaking down epileptic seizures is as a classification of seizures. This, like any classification system, whether or not you have many entities or few entities depends on whether the lumpers or the splitters are in power at the time. Currently, we're under a lumping regime, and so we tend to understand seizures now as either falling under the generalized seizure category, so that is, those are seizures in which both sides of the brain and both sides of the body appear to be involved at the onset or early after the onset of the seizure. So these are caused by a broad network of neuronal hypersynchrony or irritability, tends to involve both hemispheres, versus the focal seizures, which tend to begin not just in one hemisphere, but more typically within one lobe or even a portion of a lobe. And then there is a small number of group of seizures in which it is really unclear at the present time whether they're actually focal or generalized, and the classic example for that is infantile spasms. Below you see a long list of electroclinical syndromes. These are syndromes in which the clinical history, age of onset, the EEG, behavioral pattern, associated neurological deficits, and prognosis, including response to medical or surgical therapy, has been well established. And in many cases, the genetics have been well worked out. So this group of epilepsies is highly weighted towards those that have some kind of a genetic foundation. I'm not going to go through them in detail. I would only like to emphasize that it's often the case that precise diagnosis with an electroclinical syndrome is often of great value in choosing the appropriate medication and being able to prognosticate the chances of neurological outcome, seizure freedom, need for long-term anticonvulsant therapy, these kinds of things. Let's talk a minute about some of the numbers associated with epilepsy. It's the fourth most common neurological disorder worldwide, following stroke, migraine, and Alzheimer's dementia. It affects about 65 million people around the world and about just over 2 million people in the United States. The number that probably surprises most is that 1 in 26 individuals will develop epilepsy at some point in time during their life. There are many new cases diagnosed every year in the United States, and epilepsy, both in terms of patients as well as their caregivers, parents, siblings, children, has an enormous economic impact, assessed at somewhere around $10 to $12 billion per year. Finally, approximately 1/3 of patients suffer from seizures despite adequate trials of multiple medications. It's this population of patients that we will focus on for much of the rest of the talk. So I want to step into the field of drug-resistant epilepsy, and this has become the new term. We used to talk about intractable epilepsy, pharmacoresistant epilepsy. The new term has evolved into drug-resistant epilepsy, and this slide really captures the that evolution of the dialogue and the terminology. This is a study that was published now 15 years ago out of the Glasgow Infirmary. I've shown this before. For those of you who've heard some of my other talks, it's a study that really transformed the field of epilepsy and neurology in general. This was a study of 470 new onset patients or patients with new onset epilepsy over a 13-year period. And what the co-authors, Kwan and Brody, found was that approximately 50%, half of the patients, precisely 47% of them, could be maintained seizure-free for 1 year or more with the first medication chosen. The choice of medication was left up to the practitioner's own clinical judgment. If the first medication failed and patients required a second medication for seizure control, another 13% could achieve seizure freedom on a second medication. And as you can see, this has become a law of diminishing returns with successive trials of medications resulting in fewer and fewer numbers of patients that can be controlled adequately with anticonvulsant medications. This has led to the definition of drug resistance as the failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drug schedules, whether as monotherapies or polytherapy combination, to achieve sustained seizure freedom. So you're going to see the abbreviation DRE for drug-resistant epilepsy come up over and over again in this talk, and this is what it means. At minimum, failure of two drugs to control seizures for a significant period of time, typically 6 months to a year. So unfortunately, for most of the 20th century, the second half of the 20th century anyway, when there were alternative treatments such as epilepsy surgery, many patients waited many years for another therapy or another treatment. There was a very large multi-center study published in 2003 amongst epilepsy surgery centers that demonstrated the average duration that patients suffered from epilepsy before getting referred for epilepsy surgery was 22 years. And as you look below, there are quite long, many years of drug-resistant epilepsy, again, the failure of two or more medications, at which point in time it is pretty clear that patients stand a very small chance of getting controlled with anticonvulsant medications prior to referral to an epilepsy surgery center. So why all the fuss about drug-resistant epilepsy? So first of all, there's a fairly significant mortality, estimated at 0.5 to 1% risk per year, that's cumulative over the lifespan, during which time the patient is suffering from drug-resistant seizures. The average reduced life expectancy is 19 years for patients who have drug-resistant epilepsy, and common causes of death include drowning, trauma, suicide, iatrogenic complications, or complications from seizures such as pneumonia and status epilepticus. There's been a renewal of interest over the last few years in an entity called SUDEP. Many of you probably have never heard of SUDEP. SUDEP stands for Sudden Unexpected Death in Epilepsy Patients, and unfortunately affects somewhere between 1 in 75 and 1 in 150 patients with drug-resistant epilepsy, not an insignificant statistic. Beyond threats to life are significant sources of morbidity. These include injuries sustained as a result of breakthrough seizures, fractures, dislocations, soft tissue, and neurological injury due to traumatic brain injury and spinal cord injury amongst the most common. There are also a number of iatrogenic injuries, including life-threatening rashes, Stevens-Johnson syndrome, multiple endocrinological abnormalities associated with anticonvulsant medication, and then complications of status epilepticus, including propofol infusion syndrome, which has a fairly significant mortality risk. There are also progressive declines in memory, executive functions, activities of daily living, high rates of depression, anxiety, lower qualities of life, social stigma, loss of autonomy, primarily driving, as well as employment. As a background to some of the material, the newer material I'm going to present, I want to just set the stage and talk a little bit about the decision between medical and surgical treatment. I've already told you that about a third of patients will go on to suffer from drug-resistant epilepsy, and it takes a long time for many of them to become referred to a surgical center for evaluation. It has been the experience of many experienced surgical centers that surgery offers a long-term seizure remission treatment option for well-selected patients. I'll show you that data on the next slide or two. But the question of medical versus surgical therapy was first addressed in a prospective study by Weeb et al., based in Canada, where there was a 1-year wait for epilepsy surgery, even if you qualified for it, due to the national health system. What they found was that if they randomly selected patients to undergo surgery immediately and then followed them for a year under the study, versus routine care, which was to wait for a year and then offer them surgery, what they found was 58% who went on to have surgery became seizure-free and remained seizure-free for a year, while only 8% in the medical arm would achieve seizure freedom, regardless of what the clinician chose to treat them with. There was one death, and that occurred in the medication, not the surgical arm. It is true that some patients with drug-resistant epilepsy will achieve seizure freedom. This rate has been studied in multiple ways by multiple groups, and it comes down to about 5% per year. A patient with drug-resistant epilepsy under the care of an aggressive epileptologist or neurologist who is moving through various treatment options primarily with medications has the chance, about a 5% chance, of finding a combination of medications that will result in seizure freedom for at least a year. Compare this with surgical outcomes, and this is data from about 20 well-recognized surgical epilepsy surgery centers, primarily who performed temporal lobe resections. And what you see is approximately a 67% chance of prolonged seizure freedom, 5 years or more following temporal lobectomy for drug-resistant epilepsy. So my job is to provide the numbers to my patients who I think are surgical candidates. 5% per year with medications, 65% chance of 5-year seizure freedom with surgery. They let them make the decision, and they often make the decision that's in their best long-term interest, which is to move forward with a surgical intervention. This has led to the question of when to appropriately offer surgery. And this study, published by Pete Engel is the lead author, the ERSET study for early randomized surgery for epilepsy trial, looked at patients who had a very short period of time of epilepsy, so disabling seizures for less than 2 years. And most of my patients still, even after 2, 3, or 4 years, are still resistant to thinking openly about surgery. However, what this study quite nicely showed, this was published in JAMA, was that even at 6 months, in a small number, a small N, 14 that went to surgery, 23 that were managed with medications, the there was a significant difference in quality of life, statistically significant and improved in the surgical arm compared to the medical arm. And most patients were seizure-free after surgery. No patients were seizure-free with medical therapy. So the bar is actually set quite high with the option of epilepsy surgery, at least for temporal lobe and other well-defined focal epilepsies. So with that background, I want to turn to some of the newer developments or newer options that are available for patients with drug-resistant epilepsy. And we can keep some of those numbers in mind with the medications that we have up to date. About 5% of patients can achieve some degree of seizure freedom per year, and about a third of patients will remain drug-resistant after at least 2 or more trials. This is a complicated slide, but it's very useful because it colorfully depicts the Amazon forest of different neurotransmitters, receptors, medications. There's some old friends here: phenytoin, carbamazepine, and for some of you, oxcarbazepine. Valproate is not here. Phenobarbital being a barbiturate, GABA receptor agonist. But this slide is useful because it highlights that there are many different targets for anticonvulsant medications. And there are more that have appeared in the last year that are not even depicted on this slide, particularly inflammatory and immunological targets, as well as mTOR pathway inhibitors. So there's some cell cycle cascades, enzymes that have become a target for novel drug therapy as well. We're going to touch on a number of these medications in the next few minutes. The print here is small. We're not going to focus on it, but I'm basically just going to show you, for the sake of illustration, what drug first, second, and third generation medications look like and what we tend to use today. We don't use potassium bromide at the top of the slide anymore, but I do certainly see some patients with phenobarbital, a number on phenytoin, and a handful on primidone. Ethosuximide came out in 1958, has a very limited role in the modern treatment of epilepsy, largely for childhood absence epilepsy. In the 1960s, we saw the development of second-generation anticonvulsants, which largely included benzodiazepines such as diazepam, clobazam, and clonazepam, in addition to valproate and carbamazepine. These are all in widespread use today. I've placed a red box around clobazam because it's a medication that was not available in the United States until about 2 years ago, widely used in Europe and other countries outside the U.S. And it is a benzodiazepine, but it has been essentially engineered to minimize the dependence and tolerance issues that you see often with clonazepam, as well as the sedation, the side effects. And so it's now recently been marketed under the brand name Onfi, O-N-F-I, and is particularly useful in some very severe intractable epilepsy cases. One example is Dravet syndrome, which is a sodium channelopathy. You might have heard of Dravet syndrome in the context of Charlotte's Web and cannabis, because these are children that have typically devastating neurological outcomes with dozens or hundreds of seizures per day. Since approximately 1990, there's been an explosion of newer anticonvulsant medications, some of which remain in widespread clinical use and some of which are rather minimized today because of side effect profile. I've placed in bold the medications that are most commonly used today These include lamotrigine or lamictal, oxcarbazepine or trileptal, topiramate or Topamax, levetiracetam or Keppra, and zonisamide or Zonegran. Many of them have, in the last 2 years, come out with extended release formulations that have converted them from twice a day to once a day dosing. That further improves compliance and can translate into improved seizure control. I've listed a number of the major clinical aspects of them: hyponatremia with oxcarbazepine, just like Tegretol or carbamazepine, the rash, which we always warn patients about with regards to lamotrigine, but also the significant mood stabilizing properties. And it's also achieved an independent FDA indication for depression and bipolar disorder. What I'm going to focus on today, though, are the really new third-generation medications that I would suspect nobody in this room has prescribed, and many of you have not even perhaps heard of. And what I'm just going to bring to your attention is the fact that we have new mechanisms that have been identified with anticonvulsant properties. These are not just Me Too drugs, another sodium channel blocker, but these are drugs that target specific receptors or target specific states of ion channels that we have not had access to in the past. So a nice example of that is Vimpat or Lacosamide. And what you see in the bottom left-hand corner is the cycling of the sodium channel between the resting state, the fast inactivated and slow inactivation state, and then the open state. The open state is the state that permits current to flow, action potentials to be propagated, and seizures to be initiated. And so stabilizing the sodium channel in a state other than the open state is what many of our medications have been used for. And as you can see, phenytoin, carbamazepine, lamotrigine, oxcarbazepine, and others, including zonisamide, have all essentially focused on the fast inactivated state, whereas lacosamide targets a slow state of inactivation that lasts on the order of seconds and beyond, rather than the milliseconds of inactivity that are promoted by the traditional sodium channel blockers. Similarly, we have, potassium channel activator, Potiga. This is a completely new, first-in-class anticonvulsant that targets potassium channels, and it actually increases potassium permeability to stabilize membranes. There was initially quite a lot of interest in this medication when it first arrived. That enthusiasm has been colored a little bit, or discolored, by the reporting of significant side effect of retinal and mucous membrane discoloration that can occur. It tends to be dose-related and also related to the duration of treatment. It has to do with crystallization of melanin with the medication in these tissues, and it is reversible on discontinuation of the medication, but has scared many practitioners away from its use. Finally, the last medication that I'll touch on is Fycompa or perampanel. This is another brand new class of anticonvulsant medication that focuses on an excitatory neurotransmitter receptor, the AMPA glutamate receptor, and it tends to block or decreases the activity of that receptor. It has a side effect profile very similar to levetiracetam or Keppra. It can be associated with irritability and in rare instances, suicidal ideation, like all of these medications. But it also can be quite effective at a wide variety of seizures, both focal as well as generalized tonic-clonic seizures. It is the newest one to be FDA approved, and it's the one with the least experience in post-phase 3 studies. I'll just say a little bit about some of the data that I'll show you regarding these new medications. So we will often talk about efficacy, and efficacy of the anticonvulsant medications has a lot to do with study population. So whether patients are new onset, established epilepsy, and all of these medications are typically provided in the study context as add-on adjunctive therapy, or patients with severe drug-resistant epilepsy. So what you'll see in these 3 studies of new drugs, is typically these patients will already be on 1 or 2 anticonvulsant medications. They may have 1, 2, 3, or 4 seizures per month. And often we're looking at seizure responder rates, seizure reduction, and a small chance of being seizure-free. This is to be contrasted with patients with severe drug-resistant epilepsy. So these are typically children or young adults that have seizures on a nearly daily basis. There's chronic static encephalopathy, and they're already on 3, sometimes 4 medications, and have tried a host of others, are not candidates for brain surgery, and already have a neurostimulator in a third of the cases. So that's obviously a very different population, and that population is typically evaluated for new devices, and we're going to get to some devices at the end, as well as cannabis, and I will touch on the role of cannabis, because we're seeing the first real data on cannabis to come out of a number of clinical trials that are ongoing. So clinical efficacy, there are 3 different ways in which investigators report efficacy. First is responder rate, and that is typically the percentage of patients that achieve at least a 50% reduction in seizures. The second is median seizure reduction, and finally seizure freedom. For patients with established epilepsy, already on 1 or 2 drugs, they really are focused on seizure freedom or a significant seizure reduction, at least 70%, whereas in patients with severe drug-resistant epilepsy, high responder rate of greater than 50% for patients that are having generalized tonic-clonic seizures every day may end up being meaningful from a clinical standpoint. So I'll just show you some of the data for these newer medications. This is for Lacosamide or Vimpat, and what you see is basically 3 large clinical trials, approximately with target doses of about 400, and that has now become the general target dose for most patients, 400 milligrams of Lacosamide per day. We're seeing a seizure reduction of approximately about 40%. Aftermarket prospective data suggests that there may be a greater percentage of patients that become seizure-free over time. This is often with combination with other anticonvulsant medications, approximately 22%. This, in my mind, makes Lacosamide the best choice amongst the newer anticonvulsant medications for seizure control in an ambulatory teenage or adult population. This is data for Aptium or eslicarbazepine. This is related, the 3rd generation from Tegretol. This is an isomer of carbamazepine, a prodrug, and tends to have slightly lower chance of seizure control or seizure reduction than Lacosamide. Similar side effect profile: dizziness, double vision, nausea, vomiting in some cases. Hyponatremia becomes an important side effect. We monitor sodium in patients on these medications. This is just a list from phase 3 clinical data. Tend to start at 400 milligrams a day, increase to 600 or 800, 1200 being the maximum daily dose of Aptium or eslicarbazepine a day. I will make a brief aside about cost. We are in a complicated healthcare environment where cost is increasingly an issue, and cost is increasingly shared between employers and providers and patients. These medications are not cheap. I had a patient on Vimpat or Lacosamide who elected to go on an HSA, and he saw his monthly cost of Vimpat go from $150 to $800, and then came back asking to switch medications. Understandably so. So these medications I'm speaking about now are all still under patent and only available as brand name medications. The potassium channel blocker ezogabine or Potiga has also significant efficacy, up to 40% or approximately 40% at doses up to 900 to 1,200 milligrams per day. Recall, this is the medication that can result in discoloration of the digits, retina, and mucous membranes, so it tends to be really utilized as a medication of last resort. This is one of the, here's a slide on seizure freedom, and as we see, rates of seizure freedom are approximately the same as all of our older drugs, rates of seizure freedom of somewhere between 3.2, 4.7, 7%. Generally speaking, around the 5% annual rates of seizure freedom we've seen for all of the second and third generation anticonvulsant medications. Nothing special there. Perampanel, this is the glutamate receptor agonist. Once again, similar data in terms of seizure reduction rates. We see somewhere between 20 and 35%, and about 5% of patients became seizure-free for at least a year in the phase 3 extension study data. That was just published about a year and a half ago. So while these four new medications certainly offer new options, medical options for patients, and they are based on novel targets for anticonvulsant therapy, they do not appear to translate, with the possible exception of Lacosamide, into significant chances of seizure freedom for patients who continue to suffer from drug-resistant epilepsy. I'm going to speak for a couple of minutes. This is an entire lecture in and of itself that I am probably not qualified to give. Endocannabinoids and epilepsy. You have all heard, unless you've been living on a desert island someplace, about the role or potential role of cannabidiol or CBD in the treatment of epilepsy. Charlotte became a household name about 2.5 years ago, and since then there has been a lot of changes in terms of everything regarded to cannabis in medicine, and particularly in epilepsy. I use this slide to point out that the role of endocannabinoid receptors has been increasingly worked out. It tends to be expressed or derived from enzymes in the postsynaptic neuron, and then feedback either on inhibitory presynaptic neurons or excitatory presynaptic neurons to reduce excitation and promote inhibition. So it has a well understood role in some models of epilepsy in neural networks. About a month and a half ago, we saw the first of what is sure to be a steady stream of studies on the role of cannabidiol. This was a study that was published, lead author was Orrin Devinsky, who's been a leader in drug studies of various kinds and surgical studies for many years. And this was a multi-center study looking at 214 patients with severe epilepsies. These are generally children and young adults who are on an average of 3 anticonvulsant medications and suffer an average of 60 seizures per month. This is not your typical outpatient clinic practice. They were titrated up to 25 or 50 milligrams per kilogram of 99% pure cannabidiol provided by GW, which is the sole manufacturer of research-grade cannabidiol in this country. Safety and tolerability data were available for 162 of these patients, and efficacy was reported in a large majority of them at 12 weeks. Most of them reported some degree of adverse side effects, and those will be shown in the next slide. Surprisingly enough, even though these side effects were deemed serious in 30%, including status epilepticus in 6%, only 3% discontinued treatment. That shows you what a high burden, morbidity and mortality this population suffers from. So these families would accept status epilepticus or serious adverse side effects for the possibility of some relief of catastrophic seizures. There was a single case of sudden unexpected death in epilepsy, not thought to be attributed to the medication itself. The median reduction in motor seizures was about 36%. And I'm going to show you a little bit more of the data. This is just the slide of adverse events. So somnolence, decreased appetite, diarrhea, fatigue, and convulsion, all greater than 10%. Of those 4, convulsion was the only one that was considered serious to occur in more than 10% of the study population. This is the cumulative data on patients. Above the horizontal axis indicates an increase in seizure frequency, and below the axis indicates a decrease in seizure frequency as a percentage change. So as you can see, a very small number of patients, but remember the study population, these are kids that have 2 seizures a day on average, became seizure-free in the last 4 weeks, in the last 12 weeks of treatment, and 15 became seizure-free in the last 4 weeks of treatment. These are numbers when you broke down the data for different epilepsy syndrome, Dravet syndrome, sodium channelopathy, a well-studied genetic disorder. The numbers are somewhat impressive. These are children that have often failed every other medication available and enjoyed a 43% reduction in all seizure types, with almost a 70% reduction in tonic seizures. So these are stiff seizures that often would translate into fall and sometimes an injury related to them for patients that are ambulatory. For Lennox-Gastaut syndrome, and these are again children with a developmental delay, typically a static encephalopathy and multiple seizure types, atonic seizures. So these are what we have referred to as drop seizures in the past, very disabling with a high morbidity associated with them, 70% reduction. So there does clearly appear to be a role for cannabidiol in the management of a few well-selected epilepsy syndromes. This is a complex and rapidly changing landscape. I'm not going to spend a lot of time speaking more about this, because in a year or 2 years when I come back to give this talk again, if you'll have me back to give this talk again, we will probably have results from about 20 NIH-funded studies that are currently underway with similar devastating childhood epilepsies, but also with small numbers of patients, of adults and children with drug-resistant epilepsy. One of the issues that's arising with cannabidiol is that it does interact with other anticonvulsant medications. It can drive up the blood levels of medications like Onfi, clobazam, as well as valproic acid. And so it's important to, when patients are trying cannabis, whether it's within or outside of a clinical trial, what I have found is it's become necessary to monitor all of their other anticonvulsant levels as well as their liver function tests to make sure that everything is being appropriately managed. I'm going to talk a few minutes about devices. So why is there a big interest in medical devices for epilepsy? I've already told you about drug-resistant epilepsy, the high risk of morbidity, mortality, and disability. Epilepsy surgery provides long-term seizure freedom, as I showed you, and improved quality of life in well-selected patients. But there are many patients who undergo a surgical evaluation and are deemed not surgical candidates. Why? They may have seizures that arise from either bilateral temporal lobes. That's a very common phenomenon in adult patients with temporal lobe epilepsy, or multifocal disease. Seizures may be arising from eloquent cortex, which will introduce a focal and intolerable neurological deficit if we were to remove it. Or there may be an excessive risk for memory or cognitive loss. So in particular for patients who have seizures arising from the dominant hemisphere, the left hemisphere, we perform a WADA test. That's basically mock surgery. And on occasion, we will find that patients are likely to suffer devastating memory losses if we were to remove, for example, the left or dominant hemisphere hippocampus. These are just some pictures of some of those imagings of some of those patients. This is an image of an MRI of a patient with a double cortex or double cortin syndrome, which you can see is this darker gray linear strip of cortex. This is a band, also called a band heterotopia. So this is a band of cortex that never migrated out to the external surface. Highly epileptogenic, very difficult to figure out where seizures are coming from, if that network is even focal within the band heterotopia. This is another example of a patient with multiple abnormalities. I'll just point out a couple of them, for example. This is a bright hippocampus here. So this patient has left hippocampal sclerosis. And then this gray matter lateral to the ventricles, which you're going to see kind of expanded and nodular. These are nodular periventricular heterotopias. Also highly epileptogenic. You see the ventricles are larger and these little nodules of atypical gray matter or bilateral, very difficult to get at and identify where seizures are coming from. Here's another patient with a fairly large malformation of brain development within the right frontoparietal region. This would likely introduce a devastating neurological deficit if we were to operate on that lesion. So these are examples of patients for whom we have really no good medical therapy necessarily, and surgery is not an option. So what do we offer those patients? Vagus nerve stimulation, or VNS therapy, has been around now for FDA approved, I think, in 1998. So we have quite a long history of VNS therapy. This is an implanted device. I sometimes refer to it to patients as a pacemaker for seizures. But the purpose, obviously, is to keep the seizures away, not to keep them going. The VNS device delivers trains of square pulse waves to the vagus nerve, which has an anticonvulsant effect. There's also a magnet that can be activated by the patient in an attempt to abort an impending seizure if they feel one coming on. It's a programmable device, so things, for example, like the amplitude, the pulse width, the frequency of pulses in a train, the on time and the off time 5 parameters can all be programmed by the neurologist in order to maximize stimulation to the nerve and to minimize seizures. This technology, this device, historically has been what we call an open loop device. It's a dumb device. It doesn't really respond to anything except the programming of the neurologist or the patient holding a magnet over the device. There's there's some data on seizure reduction. This is basically responder rates. So these are patients with 50% reduction in seizures. Last year, we saw the release and FDA approval of a novel closed-loop configuration, which actually uses an algorithm and recording of the pulse in order to try to predict seizure onset. And the device now has an automatic stimulation mode that when it detects a transition between a resting pulse and an elevated pulse, and about 80% of patients will have an increase in pulse associated with their seizures, it will automatically deliver a current so that the seizures that may happen, for example, when patients are sleeping, seizures that happen where a patient can't get to the magnet to try to abort the seizure themselves, or patients who are simply unaware, they have no warning before their seizures. The device, in many cases, will detect an impending seizure and deliver a current. There's another device I mentioned last year when I gave this talk. That is a similar form of neuromodulation, except that this is actually an implanted device called responsive neurostimulation, or the RNS device. This is an FDA-approved, fully integrated, closed-loop system for detection of epileptic seizures and delivering an electric stimulus to abort. These are examples of seizure tracings from 3 patients that show a buildup of, in the top frame, hypersynchronized spike and wave, here low voltage fast activity, and here basically a buildup of sharp waves that the device has learned is the lead up to a seizure, and then it basically delivers a current to that area in order to try to abort the impending seizure. I don't know if this slide comes out very well on the projection, but basically what we now have is about 6 years of data from patients that were enrolled in the phase 3 clinical trial. And over time, there has been a significant increase up to about 2/3 seizure reduction at 6 years on average. Some patients tend to benefit quite a great deal, and some patients appear to benefit very little at all. So there's quite a variation. But this offers a novel device that can be used for patients that have frequent, often daily seizures, but cannot have epilepsy surgery due to excessive risks associated with it. I also spoke a little bit last year about for patients who are surgical candidates but are afraid of a big resection, they don't want brain surgery, or they happen to have seizures coming from the dominant temporal lobe. That's quite common. And they are at risk over time for memory problems related to the removal of a temporal lobe. And so this new technique of delivering a high-intensity laser energy that is spherically disseminated, this was developed in about 7-8 years ago, and first description of the clinical technique is now almost 4 years old. This is the lesion that is perfect for such a technique. This is a hypothalamic hamartoma. This is about a centimeter lesion right smack in the middle of the head. Very high morbidity trying to get to this type of a lesion with traditional surgical approaches, but if you place a catheter down to it with a laser probe at the end of it, and under MR guidance, turn on the laser and ablate a sphere of tissue, you can often achieve the same clinical results for these hypothalamic hamartomas, this particular etiology or pathology for epilepsy, as you can with open surgery, with very, very limited neurological morbidity associated with that. The technique has also been used for other complicated and deep lesions, such as these periventricular heterotopias. And we now have the first series of patients that have been evaluated for standard temporal lobe epilepsy, but they don't want to have the big surgery. They don't want to have the big temporal lobe surgery. They'd rather have something minimally invasive where they can go home same day or the next day, and they don't have a big scar, and it may preserve more of their language-based and logical memory. And so what we've now seen in the first cohort of patients that have been followed on average for about a year is about a 53% seizure freedom rate. Now remember, I showed you that for standard surgery, it's about 67%. So statistically speaking, there's no difference. It appears to be not quite as effective as a standard epilepsy surgery. Once again, this is minimally invasive through about a 2.5 millimeter burr hole with very limited hospitalization. Furthermore, there does seem to be a significantly improved neurocognitive outcome. Most patients are found to not have any change in various tests of logical memory, logical reasoning after surgery, compared to a significant decline that's often seen in the standard patient population. So this is brand new data. It was actually just published within the last month of a new device, laser treatment, interstitial therapy for temporal lobe epilepsy, which traditionally was a fairly significant surgical intervention. Finally, I'm just going to spend the last minute talking about new developments in dietary therapy for these very disabled kids and adults. Many of you will have heard of ketogenic diet, very restrictive diet, high in fat, low in protein, almost no carbohydrates. There's been a resurgence of interest in modified Atkins diet, and now 10 years of clinical experience with a meta-analysis that shows significant seizure freedom rates, 15% in these severely affected kids with epilepsy, again, compared to 5% per year with the medications. Unfortunately, these diets often are quite difficult for adults and teenagers to stick to, so there's been now an interest in an even less restrictive diet, the low glycemic index diet. And it turns out, in fact, that even restriction of carbohydrates with planning under a low glycemic index regimen can be almost as effective as formal ketogenics, traditional ketogenic diet. So this was an article that was, or a paper that was published demonstrated at the AES meeting in December, looking at 112 children with severe drug-resistant epilepsy. These are 3, 4, 5-year-olds. And as you can see, a third of them became seizure-free on the low glycemic index diet, whereas about almost half of them had a greater than 50% reduction in seizures. So it turns out that dietary therapy, including modified Atkins and low glycemic index, can have an even bigger impact than many of the medications, both old and new, that have come out for the treatment of epilepsy. I'm going to skip this. This is just an overview of an epilepsy program. I'm going to leave the summary up here. I'm going to thank you for your attention, and I'm happy to stick around if people have any specific questions with regards to the material I presented. So thank you very much.